The second talk is relative for general radiologists. I think if you have background of musculoskeletal radiology, that could be better. We are talking about the limitation pitfalls. Again, it's a beautiful city and friendly people. This is Taiwan, and we have 101, we have the Confucius Temple and the Tamsui Riverside, and also the Yangming Mountain. And this is our campus. We're nearby the 101 building, and we have a small campus, but it is quite quality, actually. The definition, everything is based on definition. The definition of diagnostic pitfalls is unsuspected, and is a scenario that could be vulnerable to diagnostic error, that may lead to diagnostic error. Diagnostic difficulties and limitation is the same. Limitation is something trouble during the diagnosis. That could be due to technology problem, due to lack of clinical information. If we have all the complete information, that could be okay. So this is also the limitation, restrict the accurate diagnosis. So the first part is regarding improper positioning. I will, for example, choose sample concept for all of you. So the first concept is what's regarding radiologic sign present. So I just want to introduce the fat pad, okay? The posterior fat pad, anterior fat pad. We can identify that. Why we have fat pad? Because of effusion. Joint effusion can elevate the normal fat pad so that we can see the fat pad. If we can see the fat pad, especially the posterior fat pad, we can identify or unrecognize the radial head fracture. Okay, here the radial fracture is very apparent, but sometimes the radial fracture is apparent, not apparent. It is occurred. It is hidden. So if we identify posterior fat pad, this could be identify radial head fracture by CT, but not by radiograph. So again, so the posterior fat pad side is positive for radial head fracture. Okay. So now, how about this? I have mentioned the posterior fat pad side is positive for radial head fracture. But in this case, it is a very remarkable radial head fracture, but without any presence of fat pad side. So what happened? Because we use a wrong positioning, okay? So don't use a position for elbow without 90-degree flexion. So for the elbow, we must do 90-degree flexion so that we can apply for the posterior fat pad side. If it is not 90-degree, then the fat pad side will not occur like this. It is very clear radial head fracture. The fat pad side is still absent. And if it is not 90-degree flexion, and sometimes we can see anterior and posterior fat pad side is still normal. So it's so confused. So don't use extension elbow to take radiograph, okay? Both are normal. So extension, both anterior and posterior fat pad side are normal. And with flexion, without fat pad side, is normal. Very confused. So we use only 90-degree flexion to look at the fat pad side. That is the only finding. To look at the abnormal, the red highlight for posterior fat pad side, okay? So lateral projection with 90-degree, absence of posterior fat pad, it is normal. Presence of posterior fat pad, it is abnormal. We have to look at the radial head. Okay, so forget about the extension. You don't need to remember extension radiograph. Just repeat the radiograph in 90-degree. So don't use it for interpretation. Okay, this is the first concept. The second one, you do MRI of the shoulder, so many cases, but ask for the technologist to put the patient arm in thumb up. Thumb up is something like when you lie on the table, thumb up, okay? Or slightly external rotation is acceptable. Don't do internal rotation. If we do internal rotation, we can see a gap over here, like supraspinatus tendon tear. Actually, they are the same patient. Okay, both the same case. If we do a natural neutral thumb up position, we can see the supraspinatus clear, continuous in low signal intensity. But however, if you do an internal rotation, then we will see a gap with high signal, then we'll mimic a tear. So do it in thumb up or slightly external rotation is acceptable. Okay, so the two examples for the improper positioning, and the second one is inappropriate workup. So this is very common for the emergency department. We can see the AP view of the wrist. We cannot identify any fracture. But however, if it's a cord fracture, after we do a radial oblique view, we can see the hamate fracture. So why we do the radial oblique view? Because of the clinicians should do physical exam. They have to identify which part is painful so that he can order the next X-ray. If the clinicians don't have any time to do the physical exam, they send for patient to the emergency radiographic radiology center, then it will mimic so many cases. It will mistake so many cases because we do screening. We are not doing problem solving. So we need to do problem solving. We are not health exam center. Emergency department is not a health examination center. We don't do screening. Ask the clinicians to screen the patient, to ask the question. We only do problem solving, okay? So in this situation, we can do oblique view, we can do whatever they want to find out the problem. So we do problem solving, not screening. So how about this? Still, we cannot see any fracture, but after the third view of scaphoid view, we can identify the fracture over the scaphoid bone. This is very common. So the problem is also the reimbursement. In Taiwan, usually the reimbursement only allow for 2 views. That is the payment for 2 views on the first exam. So usually we cannot do the third view. If the patient would like to pay for the third view, that's okay. But usually we don't do the third view. So the third view is very universal in the other countries, especially in the Western, or even do the CT scan. So how can we solve the problem? Ask the patient to follow up. Very important. Ask the patient to follow up in 2 weeks. Yeah, from non-displaced fracture to displaced fracture, at least you can capture the fracture. So of course, you have the budget. You can do CT scan. So some data. In the 2015 and 2008, we can see the population of the CT scan can identify more fracture as compared to radiograph. Of course, the reason is there are 4 bones overlapping on the AP view. As we indicated, the trapezium, the trapezoid, they are overlapping each other. The hamate and also the pisiform and triquetrum, these 5 bones are overlapping each other. So even the scaphoid bone is not fully depicted on the AP radiograph. So these are occult fracture. We need more films, more projections to identify the subtle fracture. So especially the clinical exam is very important. As I mentioned, if you don't know, then follow-up. Follow-up is very important within 2 weeks. And if you like, you can obtain a CT scan, but don't overdiagnose. Okay, so the first point is the very common findings for the emergency for the wrist joint injury. The important is the, again, for the follow-ups within 2 weeks, ask the clinicians to do problem solving, we are not screening the patient, and do more than 2 views, okay? The second one is, it's a normal radiograph AP and lateral view for the shoulder joint, still missing so many things. The clinicians should point out the problem is shoulder dislocation. So as for shoulder dislocation, don't forget we have the responsibility to point out we have to use the axial view so that we can see the heel sac fracture. Otherwise, we will miss the heel sac fracture. As we can see on the AP view and the Y view, the ball of the shoulder joint is still okay. But on the axial view, we can see the heel sac deformity. So for this case, a vertical fracture on the knee joint, on the tibia, and even on the femur is very hard to see. Yeah, sometimes it can be missed by radiologists. But on CT scan, a horizontal fracture is very easy to be identified, especially on the reformated sagittal view. So finally, what is the rule to interpret the radiograph? The rule of twos are very important. We have at least 4 points, and some of the literature have more than 4 points, whatever. So 2 views, of course, we have to AP view and natural view can reduce the errors in the fracture. 2 investigations consider CT scan, MR imaging, and ultrasound usually less performed in musculoskeletal radiology. And we also need 2 visits, that is follow-up study, to bring back the patient in repeat exam in 2 weeks. And 2 points, 2 joints, image the joint above, not only the joint that we have to identify on the painful joint, but also in some cases, especially in ankle joint, we have to identify the knee joint as well. Okay, the third part is imperfect gold standard. Sometimes we use the gold standard, but which is not perfect. For example, here we can see the root fracture. The root fracture is usually located on one slide only. We can identify on the coronal view, or sometimes we can identify on sagittal view. It is the posterior margin of the meniscal horn tear, but in that part usually can be missed by arthroscopy. So an arthroscopy negative could be false negative, and it is not our MR imaging false positive. So when a surgeon, when an orthopedic surgeon argue with you, okay, we can't see anything, your reporting has meniscal fracture in the posterior horn, and in our scope, we see nothing. Yeah, you make a joke to me. No, it is not a joke. It is true meniscal fracture. It is false negative by the scope. It is not false positive by MR imaging. This is a very important concept, because as for the scope, the angle to tilting to see the meniscal tear and then to use the prop to insert inside the meniscal tear is difficult. So the surgeon usually can mistake, can overlook the meniscal fracture, especially for the posterior horn of medial meniscus. They are false negative, although they will not happy, okay, because you argue with him. But it is the fact. Okay, so. And how about the lateral meniscus? Still, it is very common to have false negative lateral meniscal tear on MR imaging, not by the scope. Okay, scope is perfect. Scope to view the lateral meniscus is perfect enough. But for the MR imaging, we have anterior cruciate ligament tear. Then we will easily overlook the lateral meniscal tear. I don't know the reason, but it is, by statistic, it is common. So for the scope, it is very easy to overlook the posterior horn of medial meniscus. Overlook means underestimation. It is false negative. So MR imaging is correct. But as for the lateral meniscus, MR imaging could be underestimate, could be overlooked, false negative. So arthroscopic is correct, okay? So a little bit reverse. Okay, so the third one is regarding the artifacts. Now, as we know, 2D image is for diagnosis. The reformated image is never used for diagnosis, just for eye-catching. It is just for explanation to the patient, it's more easy communication with the surgeon, something like that. Usually we diagnose this based on 2D raw data image. For the left-hand side, we can't see anything on the radiograph, but unfortunately from the CT scan, we can see the fracture. But is it a real fracture? No, it is not a real fracture. Because if we use the old model CT scan, it is just steps artifacts. This is false positive. So we have to solve this problem by the Y collimation and non-overlapping reconstruction helical CT scan. I think here everywhere is the overlapping, everywhere is the helical CT scan. We don't need to worry about for the even 64 slices CT scan. So how about the MR imaging? MR imaging more common to have tendinopathy in proton density image because of the magic angle. So in practical, just use the heavily T2 image. That is the spin echo over 80 milliseconds for diagnosis of tendon or ligaments. And we use proton density, that is the echo time between 20 and 40 for diagnosis of meniscus. Okay? The reason for that is for meniscus, if we use heavily T2, that will cause too much noise. Then we'll underestimate the meniscal tear. So for meniscus, we use proton density, that is between 20 and 40 milliseconds. But as for the tendon or ligaments, we must use the heavily T2, that is the 80 millisecond echo time for diagnosis of tendon tear to avoid the magic angle phenomenon, that is the 54.7 degree of magnetic field. This is a very important example from our case. Here we can see, okay, from the literature, here we can see the proton density on the left. It is a supraspinatus tendon tear. But on the right, the heavily T2, that is the echo time over 80 milliseconds, we can see a low signal intensity without any supraspinatus tendon tear. It looks like a supraspinatus tendon tear. So it is no tear, it is normal. So for the magic angle phenomenon also will occur in the angle, in the shoulder, and even in the wrist joint, okay? Number 4, how about the atypical or mimicry? Okay, this is a little bit like a knowledge base. Which one is abnormal? The left one is the right one. Okay, as we can see, the left one, the perforation is in the middle, but don't forget, in the middle is this degenerative perforation. This is due to aging process. Degeneration is the phenomenon, is not a disease. So a disease is a disease. A phenomenon is just an observation, it's not a disease. Don't treat the observation. Don't treat your observation. We are not treating the image, we treat the patient. So a tear is a disease. Okay, traumatic tear usually occurred at the radial attachment or ulnar attachment with hyperintense signal and also a companion with joint effusion. Although this patient also accompanied with joint effusion, this is due to degenerative tear, is the long-term tear. And it looks like normal. It is very common in emergency department, especially the emergency department can be run by a resident training doctor without any experience. It is not normal because the joint is not overlapping. So a normal AP wheel should be overlapped from the glenoid humeral joint, that is the ball, should be overlapped with the socket joint, okay, ball and socket. So it is a ring sign. Posterior dislocation. Posterior dislocation usually posterior superior, anterior usually anterior inferior. So we can see a separation of the ball with the socket, then it is posterior dislocation. One wheel diagnosis, no argument. Okay, how about this? And our patient is a 42 years old man, suffer from bilateral hip pains, and we can't see anything on the radiograph, but as for patient, it's very painful. So do MR imaging, diffuse disease look like infectious process, look like metastasis. And then we do bone scan, and we can see the hyper optic hotspot over right side, but not on the left side. It is quite strange because on MR imaging, both sides and very severe, so mismatch. So it is not metastasis. This is some kind of staphylococcus infection, and even on the shoulder, okay? Which one is abnormal? This is all related to the anatomy. We have to identify the posterior cruciate ligament first. On the left-hand side, it looked like a buccal handle tear because it is buccal handle tear because for the second PCR, that's a double PCR sign, is inferior to the original PCR, right? To the anatomical PCR. This is the meniscal tear fragment. But this is not a meniscal tear fragment. This is attachment to the posterior tibial plateau. It is a posterior cruciate ligament. So the ligament above it is the ligamentum of Winsberg. So we have to identify the normal anatomy. It is not a fracture. It is not a meniscal tear. How about this? Which one is meniscal tear? So first of all, we have to identify the medial meniscus is the posterior horn slightly bigger than the anterior horn. So here we can see the vertical abnormal signal. So if we can identify the asymmetry of posterior horn, the posterior horn should be bigger one. So this is a tear. But for this one, the meniscal like this is too big, right? So, okay, this is false positive because of the hyper signal is mislead us to identify this is a tear. Okay, sorry for the confusion. And for the right side, it is a true positive because even both have contusion, but for this one, because we have a bigger posterior horn, so the bigger posterior horn is normal. And within the normal, there's a vertical tear. This is the true positive. Incomplete visualization of the scope, both are positive. Okay, so a scope could be false negative again. So for the last case, both are positive because we have to identify the larger posterior horn as compared to anterior horn. First, have to make sure the concept over here. We have to make sure the larger posterior horn, yes, it is larger, including the vertical abnormal signal posterior to it. It is a normal meniscus. But within the normal morphology, we identify a vertical tear over here. Okay, the same. We identify the posterior horn is larger than the anterior horn. So the larger posterior horn have a vertical abnormal signal, then this is a tear, even though the arthroscope reveal negative because of the scope false negative. Okay, this is true positive on MR imaging and false positive when we use scope as a gold standard. So misuse the gold standard, okay? A little bit confused. So for young kids, young boy, sometimes we can see the hyperintense signal even on fat suppression image on T2. It is normal. Don't identify it is an infection or some other hematogenous disease. And how about this? Don't forget the modic type. One, it is the hyperemic change. Okay, hyperemic change is the reaction to the degenerative disc, and it may not recognize as abnormal. This is just the hyperemic. And how about this? Don't say it is the metastasis, even though we can see the bulging posterior vertebral body because we can identify the fat over there. Usually metastasis, we cannot identify the fat within the vertebral bone marrow because of the metastatic cell occupy the vertebral bone marrow. So both are traumatic fracture, not metastasis. Okay, the last one, poor knowledge. Okay, just go through a little bit faster. As we can see on the left-hand side, we can see the widen of the clear space of the medial joint. And we have to remember the rule of two. That is, okay, the one joint is abnormal. You may find another joint is abnormal. So we can see the fracture in the proximal part of the fibula. It is very common for mid-sole injury, very common. So in the emergency department, when we identify just a joint dislocation in the ankle, don't forget to have a second view for the knee joint, or you can order a long bone X-ray to look at the proximal tibia or fibula. Okay, as for shoulder impingement, this is clinical diagnosis. As I see about 20 years ago, so many reports and in the literature emphasize the hook meniscus could be one of the anatomic abnormal to cause impingement syndrome. But even though the acromiectomy, that is acroplasty, that is remove the spur from the acromion, the patient still have painful shoulder. Why? Maybe this is aging process. So usually we treat the aging process, we are not treating the disease. So both the tendon and also the bone are degeneration. This is not caused by the spur, okay? So when we see the spur, we remove the spur, the patient is still painful because of the degeneration of the tendon. It's not due to the spur formation. So we are not treating the patient, we treat the X-ray, we treat the MR imaging. This is the error. So an observation is not a disease. An observation is the phenomenon. A phenomenon is not a disease, it's a risk of disease. So what we need to dictate it on the radiograph or MR imaging, I would say, okay, we can identify a spur in the subacromium, which is the risk factor for shoulder impingement. I will not say, okay, subacromium spur formation are consistent with or compatible with impingement syndrome. I won't say that because impingement syndrome is a clinical diagnosis, not radiographic diagnosis. If we use radiographic morphology to fit for the clinical diagnosis, that could be an error because this is just an observation, not the disease. This is the risk. Okay, how about this? Clear, it is the fact. We can see the meniscal tear over there, right? But don't forget, order an X-ray, we can see the calcium. So calcium not only depicts low signal intensity, calcium can be high signal intensity because the calcium cover by water-bound image, bound sequence, so that we can identify the calcium in hyperintense signal. The calcium itself could be low signal, but bound by water, then could be hyperintense signal. So no meniscal tear. And also for the cartilage, same. And I need to get a little bit rush, change your mind, low-grade liposarcoma and lipoma. How do we identify these two? Because we have to identify the septum layer by layer. Here we can see the uneven size thickened septum. This is a sign for abnormal sarcoma, okay? So lipoma usually have even sized thin septum, but liposarcoma usually have mural nodules or uneven sized septum. But as we know, neurogenic tumor like schwannoma, lymphoma usually have depict fat pad sign and have an ovoid signal with so many ducts like that. But degeneration is very common. So don't forget, it is a typical cystic degeneration in schwannoma. And how about that? Usually our concept is metastasis, usually in bone marrow, but don't forget, lung cancer usually may have cortical metastasis, just like a cortical bite, okay? So metastasis not only from the bone marrow, but also can be in long bone, cortical bone. Okay, just take home message in proper positioning, especially in the wrist, especially in the shoulder joint, in appropriate workup due to incomplete projections. and imperfect gold standard. And all of this, don't forget the rule of 2, okay? The gold standard, you have to argue with the surgeon, need more information, and especially the emergency department, typical mimickers, you have to build up your knowledge. Artifacts, you have to avoid to teach the technologists, to technicians to do a quality image. And also the poor knowledge, we have to attend more continuous education course. Thank you very much for all your attention. Yep.